Okay. This is working. Okay, thank you. Thank you for the introduction and the opportunity to present our study on uninstrumented fusion and 10-year cost effectiveness. So these are our disclosures. The patients in question are patients suffering from spinal stenosis, who suffer from back and leg pain, which is worsening when standing and walking, and better when they forward flex. Choice of treatment is often decompression with or without spinal fusions of the affected levels. In the elderly population, bone quality is a consideration when performing fusion, with an increased risk of reoperations, complications, and poor outcome. The objective of the current study is to determine whether choice of bone graft material affects the long-term cost effectiveness after decompression and fusion due to lumbar degenerative spondylolisthesis. This study is based on an RCT from 2013, where we randomized patients to either Allograft bone extender or ABMP15. The original study was a randomized controlled trial. It was double-blinded. Obviously, surgeons weren't blinded to the choice of bone graft material. Patients were divided in two groups, 1-to-1 in each group. We included patients with 1 to 2 level degenerative spondy, age 60 and above, with symptomatic neurogenic claudication. All patients have confirmatory MRI revealing spinal stenosis and standing X-rays. We chose patients with a symptom duration of at least 3 months of failed conservative treatment. Exclusion criteria were prior spine surgery, dementia, current fracture, unwillingness to quit smoking, and a degenerative scoliosis more than 20 degrees. The surgical technique was midline sparing decompression in both groups, with graft material packed in the posterolateral gutters. The only difference was the choice of bone extender, which was Allograft in one group and ABMP15 in the other. We collected data on the health-related qualities of life from EUROQAL at preoperative, 1 and 2 year, 5 and 10-year follow-up, and at 10-year follow-up we examined patient charts for use of health resources and reoperations. From the patient charts we got cost variables on the in-hospital costs, on the radiology used and the implants used. Okay, for the results, the original study had 101 patients. Age was 70.5 mean, mostly were women, and 60% had leg pain for more than 12 months. We lost 23 patients to death during the study, some more declined follow-up, which left us with 27 patients in the Allograft group versus 30 in the P15 group. For our health quality of life anchor, we used the EUROQAL, and the slight difference we see over the 10-year follow-up gave us a difference in QALY of 0.5. We'll remember that for later. We looked at the reoperations. We had 43% reoperations in the Allograft group versus 80% in the P15 group. On this survival analysis, it looks like the P15 group had a better durability of the fusion than the Allograft group. On the use of health resources, well, in the Allograft group, they spent more resources in OR time, in-hospital visits, surgical visits. Obviously, the reoperations from before, the phone calls was about the same, and radiology, there was a significant difference. When combining these resources from the hospital, from the implants, and from the radiology, we found a cost difference between the groups of about 20%. This is in Danish kroners. To make the choice whether treatment is useful, you have to look at this incremental cost effectiveness ratio. Obviously, we all want to be in the lower right quadrant, where it's cheaper to do and it's better, higher effect. We wouldn't like to be in the top left, where it's more expensive with less effect. We did bootstrapping with 1,000 replicates to see where we would end up, and the red dot in the middle is our mean, with a cost difference of this 20,000 and a difference in the quality of life of 0.5. The limitations to the study, well, it's 1 and 2 level fusions. We have no deformity cases, and about 20% were lost to death. The strength is a double-blind RCT. It's a standardized calculation of the cost variables, and we have a 10-year follow-up. So based on the study, we choose to conclude, well, for the Allograft group, they spent more health-related resources, they were more expensive, and there was a slightly better treatment effect in the P15 group. Thank you very much.